to Dr. Babitha. She will be talking on thinking beyond topical steroids in uveitis.
Good afternoon. There are multiple treatment options other than topical medication for uveitis. This include periocular injections, systemic treatment, immune modulatory agents, newer options, and vitrectomy. The periocular injections include subconjunctival injections, subtunnel injection, intravitreal, suprachoroidal space injections, and transsternal retrobulbar injections. Indications of periocular injections include if a patient is non-compliant to topical medication or partially responding to topical medication, or there occurs a breakthrough inflammation during topical medication, or is considered as an alternative to immune modulatory agents. Infectious uveitis and associated scleritis are contraindications for periocular injections. Triamcinolone, acetonide, dexamethasone, and betamethasone can be given as subconjunctival injection. The other indication for subconjunctival injection is uveitic macular edema. This video is not working. This is how the subconjunctival injection is given. The subconjunctival injection is given. And then the subconjunctival injection is technically very easy, but one disadvantage is chance of glaucoma is there, but it will respond to topical medication. If it is not responding to topical anti-glaucoma medication, we can easily remove the subconjunctival drug deposits. Single subconjunctival injection of liposomal triamcinolone acetonide phosphate induce effective and sustained anti-inflammatory action in experimental uveitis. Triamcinolone acetonide 40 mg per ml, 0.1 ml, and methylprednisolone can also be given as subtunnel injections. Other indications include intermediate uveitis, posterior uveitis, and uveitic macular edema. These injections can be repeated 2 to 4 weekly. If there is no response after 4 injections, it is considered as failure of the treatment. And the effect is less compared to intravitreal injections since the scleral penetration of these drugs are less. These subtunnel injections can be given as supratemporal injection or infratemporal injection. The complications of supratemporal approach include severe steroid-induced glaucoma, upper eyelid ptosis, periorbital hemorrhage, and globe perforation. The infratemporal transseptal orbital fold approach has the complications like periorbital and retrobulbar hemorrhage, lower lid retractor ptosis, orbital fat prolapse with orbital festone formation, and orbital fat atrophy and skin discolorations. Triamcinolone acetonide can also be given as suprachoroidal space injection with suprachoroidal space microinjectors. They are available with 2 microneedles of 900 and 1100 micrometer to accommodate patient variations. The microneedle is inserted into sclera 4 to 4.5 mm behind the limbus perpendicular to the surface, and loss of resistance indicate the microneedle in the adequate position. Then inject drug slowly over 5 to 10 seconds. Then keep the needle 3 to 5 seconds for the drug to dispense. It is given in uveitic macular edema, and the anterior segment complications are less for this approach since there is preferential distribution to posterior segment, but patient may have eye pain on the day of injection. Then various intravitreal injections are available. They include triamcinolone, dexamethasone, and fluocinolone acetonide. Triamcinolone can be given as pars plana injection 40 mg per 1 ml, 0.1 ml as pars plana injection with 30 gauge needle. And this injection can be repeated 3 monthly. The disadvantages include glaucoma, rhegmatogenous retinal detachment, and endophthalmitis. This is how intravitreal injection is given. It is given 3.5 to 4 mm behind the limbus. Then triamcinolone acetonide implants are also available. 0.4 into 0.21 mm titanium helical non-biodegradable implants can be surgically inserted into the vitreous cavity. It contains 925 microgram triamcinolone acetonide, and drug delivery lasts for about 2 years. This helical design increases the surface area of drug delivery and stabilizes the implant. This is the implant. In point trial, the intravitreal triamcinolone acetonide and intravitreal dexamethasone implants were found to be superior to periocular triamcinolone acetonide in treating uveitic macular edema with a modest increase in the risk of IOP elevation. And this risk did not differ between these drugs. Dexamethasone pellets contain 700 microgram dexamethasone available. They are biodegradable and used in posterior uveitis and intermediate uveitis. Can be retained in position for 3 to 6 months. But the complications like glaucoma and cataract is there. And the relative contraindications are aphakia, post-vitrectomy style, absence of lens capsule. There is a risk of anterior chamber migration of the pellet. Then fluocinolone acetonide implants containing 590 microgram fluocinolone. It has to be surgically implanted into a vitreous cavity. It is effective for 2.5 years. The complications include glaucoma in 75% in patients. 100% of phakic patients can develop cataract. Then chance of endophthalmitis, wound leak, hypotony, vitreous hemorrhage and retinal attachment is there. But this can be reimplanted or exchange are possible. Then fluocinolone acetonide injectable inserts containing 0.19 and 0.18 milligram fluocinolone is available. They are non-biodegradable and can be retained for 3 years. But the complication is like cataract and glaucoma is there. In MUST trial, they compare the intravitreal fluocinolone and systemic steroid in posterior, intermediate and pan uveitis for the visual recovery. But there is no difference in the visual outcome. Then transtinin retrobulbar triamcinolone infusions are available. This is given as 0.5 ml of 40 mg per ml triamcinolone, indicated in vitritis, cystoid macular edema and retinal vasculitis. Cataract and glaucoma is less since there is preferential distribution to posterior segment only. But it cannot be done in sitting position and under slit lamp. It has to be done in the operation theatre. Then systemic steroids are indicated in bilateral uveitis, severe vision threatening uveitis, periocular steroid, when periocular steroids are contraindicated, or lack of response to periocular steroids and associated systemic diseases. The oral prednisolone is given as 1 to 1.5 milligram per kilogram body weight, not more than 60 mg per day, and has to be tapered very slowly. Or intravenous methyl prednisolone can be given, it also has to be tapered slowly. There are multiple complications are there for systemic steroids. Then immune modulatory agents are considered if there is systemic steroids are contraindicated or patient develop drug dependence or the complications are intolerable. And it will be dealt later. And the next is gene therapy and RNA interference is available for non-infectious uveitis management. Then vitrectomy is done in cases of uveitis with severe media opacities like cataract or inflammatory exudate or hemorrhagic vitreous hemorrhage for improving the visual acuity or to visualize the posterior segment. Or in case of endophthalmitis and lens-induced uveitis, inflammatory to control inflammation, and in structural complications of uveitis like retinal attachment, epiretinal membrane or chronic hypertony, or to for sustained intravitreal drug delivery purposes. The take-home message is treatment of uveitis is a double-edged sword, so be careful to avoid unnecessary complications and adverse effects. Thank you.
Thank you, Dr.